Vivien Dugan, Professor at Johns Hopkins Bloomberg School of Public Health, Dr. Andrew Pekosz, and Vice President of North America Commercial Operations for CSL Seqirus, Dave Ross. This conversation on influenza strategies in the age of COVID will be moderated by Maggie Lake, veteran journalist and founder of Maggie Lake Media.
Hi, everyone. Good morning. It's so nice to see everyone and excited to talk about this. We were all just chatting for a moment outside, and I said, oh, it's summer. We can relax. Everyone's focused on the beach and vacation. We're not at all thinking about pandemics and flu. But they all are. That's their job, is to worry about it and think about it strategically ahead of time to help protect us all. So we're going to be talking about influenza strategies, flu strategies in the age of COVID, really in the wake of what we went through with the COVID pandemic. But Vivien, I wonder if you could kick us off and just sort of set our expectations. What are we anticipating? What are you tracking for the coming flu season?
Sure, that's a really great question. I think it's twofold. A lot of the work that we do at CDC is part of seasonal influenza surveillance, and so we're tracking and checking and making sure that we know which viruses are circulating in the US and globally each year. But that serves as an exercise for us for being prepared for pandemic influenza as well. So pandemic influenza can start anywhere in the world. These are often viruses that come out of the animal populations, wild birds and swine, and can make people pretty sick. And so I think that as we are ready for seasonal influenza, we had a pretty robust season this year in the US with the co-circulation of COVID-19 and RSV. We are watching what's happening around the world in the Southern Hemisphere to make sure that we are ready for whatever may happen in this coming season in the fall and the winter months.
So do we anticipate it's going to be worse? Do we know yet? Are we able to sort of forecast out what we're expecting?
Yeah, it's really challenging. I think if you've seen one flu season, you've seen one flu season. This is one of our many sayings in the flu space. We don't know. We do watch and analyze what's happening in the Southern Hemisphere quite a bit. And so we're seeing activity in Australia, several other countries like Bolivia, Indonesia, as well as Chile that have started in earlier, a couple weeks to months earlier this year. And so that could be an indication that we may have an early season. But there's a lot of factors that play into this, from population immunity, available vaccination. Viruses change. When we think about flu, it's not just one virus. It's actually 3 to 4 viruses each year that circulate around the world. And so it's always flu season somewhere. So in the Northern Hemisphere, it's our winter, but right now it's winter in the Southern Hemisphere, and so that activity is starting to pick up.
Yeah, and as we know, we are all back on planes, traveling, sort of catching up with everything we missed, which is fantastic, but also probably means that we're going to see a lot more people moving around the world and circulating, which probably raises the risk. Andy, how does this plug in now, or how are you all approaching this and thinking about this in the wake of the COVID pandemic? Have we learned things? What are the lessons coming out of that may apply when we think about flu pandemics?
Yeah, I think that the most compelling thing was understanding how quickly we could gear up and rev up and increase our capacity to do things given the resources. Certainly with COVID-19, we went from virtually nothing to being able to do at Johns Hopkins thousands of tests a week over the course of a month. And we can do the same thing with influenza if that's needed, if that's necessary. But it's also about preparation. As Vivien mentioned, there are lots of different flu strains out there, making sure that our testing is in place to recognize each of them effectively, making sure we don't just test, that we have the follow-up strategies in place to be able to treat people or give people the appropriate advice when they are infected. And I think the other thing, too, is understanding that influenza season is also respiratory virus season. And people are infected with lots of other viruses potentially at the same time. And we now understand that we can actually gear up and be able to maybe test for lots of different viruses to give people more information about what they're sick, as opposed to just I'm feeling sick, but I'm COVID negative, so off I go.
Yeah, well, this raises a really interesting point, doesn't it? Because it's kind of changed how we think about it, because especially in the early days, the severity of COVID-19 and your concerns about it, your concerns about spreading it to vulnerable members of your family. In the wake of that, everything else seems like, well, it's not going to kill me. So that's a challenge as we move forward.
Absolutely, yeah, and flu could be very, very devastating.
Right.
In some of the worst years, you could see over 40 million people sick. You could see 700,000 hospitalizations and up to 50,000 deaths. So it's a really, really significant virus, but it does kind of get muted out by all the last couple of years in the pandemic that we had to manage through. So, it used to be that flu owned the fall for
Yes.
immunization, and now there's a challenge where flu has to share with COVID immunization and prevention, and now potentially RSV is also going to be something that's immunized probably at the same time. So it's been a very interesting story around flu. People think of it as kind of a very stable environment, but if you look back over the last decade or so, there's been tremendous advances in recommendations, moving from condition-based to universal recommendation, changes in access points around retail, new vaccines being launched that provide better protection. So the decade before the pandemic, there was a general improvement in immunization rates and protection. Pandemic hit, and obviously it had to take priority, and luckily we now know that flu was very little flu activity, so we were able to focus on COVID at the time. But we've gone from the peak of immunization for flu just 3 years ago to now we seem to be in a drop in immunization rates. So we're competing with just fatigue that's out there. We've got changes in the access points. We were just talking just before coming on that what is driving the lower immunization rates for flu, and one of the things we have to look hard at is access points. So many people got immunized at the workplace, but not as many people are returning to the workplace. So where are they going to go for their immunization? So working with health authorities, with the physicians, the immunizers, the pharmacists, and the industry, we have to figure out how do we get this track back in the upward direction of increasing immunization rate, because the consequences can be very, very severe for flu.
I think you said a lot of things there, and I want to unpack all of them. You mentioned something about the improvements. I think you said condition versus something else. For those of you who are not as deep in this, what do you mean by that?
So at one point, immunization recommendations for flu were based upon condition-based recommendations. So did you have a weakened immune system? Do you have some underlying medical condition, like were you a diabetic and therefore recommended for immunization? It was then learned that trying to screen for those types of patients was difficult in a very short period of time. So the CDC went to an age-based recommendation where it was everybody 6 months and above should be immunized. So now if you walk in, if you're 6 months or above, you're recommended for immunization. And that made access much easier, and it made the immunization rate, increasing immunization rates.
Lowered the bar.
Yeah, lowered the bar.
To figure out whether you were eligible or not.
That's right.
Vivien, the fact that so I don't know that that a lot of us realize that the immunization for flu sort of fell off the cliff, it sounds like.
Yeah, during the first year of the pandemic, we hit the high of about 172 million people immunized. Last year, it's estimated that less than 140 million. So there's been over a 30 million dose drop-off in immunization.
Which is understandable because we weren't leaving the house. So it wasn't as much of a concern. It wasn't as prevalent. We didn't see it. Vivien, that's got to be a concern based on what you just said we're expecting, and which sounds like there's a lot to be concerned about, and yet we've got to claw back all those immunizations.
Yeah, no, that's completely spot on. All vaccinations, especially childhood vaccinations, really dropped off during COVID-19. But for influenza, we are seeing significant drops for pregnant people for influenza vaccine, for those with underlying conditions, which make them, again, at higher risk for hospitalization and death. And so those very immune compromised or vulnerable people, very young children, are at the highest risk for any type of severe outcome. But then we're also seeing, of course, a lot of the same kind of mirrored changes that we've seen with COVID-19, where we've got health disparities and health inequities that are happening in certain populations, where access seems to be one of the reasons why we're not getting shots into arms for influenza, as well as an increasing change in disparity between rural and urban communities. And so in thinking through all of this, part of our campaign at the CDC for influenza vaccination this year, it's our third year performing this, is to really focus on reaching those individuals to try and get those numbers up. So not only for parents who have children aged 6 months to 12 years, but also for those who are at higher risk, kind of those underlying conditions, immunocompromised, as well as health disparities, so Black and Latino populations, and then of course that rural and urban populations, to really kind of bring those numbers up.
Both Andy and Dave, why are we seeing those disparities? Because looking at it from a layperson's point of view, I felt like so many of us got pulled into systems because the COVID vaccine in many cases was mandatory. So we were reaching into pockets of people and figuring out they were mobile. I still see, tents up in New York City still to this day. Many, they're very few and far between, but they were on every street corner in major cities. You would think that more people would now, that infrastructure would be created where more people would have access. Why are we still seeing disparities? Andy, let's start with you.
I think it's critical to understand that communication has oftentimes been an underlooked part of the messaging around vaccines. And understanding how to communicate to vulnerable populations, to different populations effectively, is something that we haven't really invested enough time in. It's certainly one thing when you say it's mandated, then people line up, and even if there's a little bit of hesitancy, they'll usually line up and get their vaccine if it's mandated. But as soon as you take that mandate away, it falls on the communication part of it to make sure that people are not only understanding the benefits, but that you're communicating to them in ways that resonate with them, through the right channels, through the right people and individuals to get those messages across to people. And again, I think we've always sort of known that was an important part of the communication process, but I think now we're really understanding how critical it is to get to some of these populations that are normally under-vaccinated.
And I think adding to that, there's some structural things that have changed during the pandemic. I believe the number is something like over 300,000 healthcare providers have left that industry. So there are over 300,000 fewer healthcare providers out there. So the strain on the system is greater. I think that there are some challenges around access points. We're still trying to figure out what does the workplace look like, and where should we go to get immunization. That's been disrupted more through this pandemic than ever before. So I think there's a settling out there. And I think, unfortunately, because of the politicalization of vaccines, it's making the conversation between the healthcare provider and their patients more difficult. So where we know that historically, that 80% of the time, if you get a firm recommendation from your healthcare provider, the patient's going to follow it. I think the healthcare providers are a little bit more hesitant to be firm, especially when it comes to vaccination, because of all the debate that's going on around the mandates and how the COVID program was implemented, at least in some people's minds. So I think they're less likely to engage in the same way they did. So these are all challenges that we have to identify and then start chipping away at them one by one, so that we can start changing that direction.
And you mentioned conversation. That's if you're having one, because of the nature of the changes in the infrastructure, which I think we all agree are fantastic for convenience. I run in to get my toothpaste and I say, oh, I'm at CVS, I'll get or Walgreens or whatever your provider is, I'll get my shot while I'm there, especially if it's not as busy now. So the appointments you could do it on your phone right there and get it. That's great, but that's very transactional. I'm not having a conversation with the same person who's filling 8 million prescriptions and doing something else. So the idea of if I have concerns, who do I talk to about it? Vivien, that must be a concern from a sort of health point of view, when you're not actually having a conversation about the flu season and the need for it. Forget about how it works with everything else that you're in line to get.
Yeah, and one of the things that we've really tried to do at CDC is to really double down on social media and working with trusted partners, community leaders, people who can reach those individuals, not just a physician or not just someone in the healthcare community, or of course, you're going to a pharmacy, and I think it was over 1 million more doses of flu vaccine were actually given out last year at pharmacies. And so trying to get that message out from people that communities know, right? Whether you're a pregnant person, whether you're from an urban or a rural location, and also we're starting to get those materials out sooner. So this is going to be the first year where we're actually starting in September, and so all of our communication assets and materials are going to be available in September at the beginning of the month, so we can start getting that message out sooner than later.
Yeah, and that is a change, right?
Yeah, I was just going to comment that the public-private partnership that has to happen in this arena is critical. So we look, even though we're an industry, we look to the CDC for direction. As soon as those materials come out, the most important thing is that there's consistency in the messaging. So we don't come up with our own messaging. We follow the
Well, that's
the
the lesson
messaging
from COVID, isn't it? The inconsistency or the crossover. And granted, it was happening in real time on a scale that it's never been happened before. So I think it's understandable that that was the case because everyone was learning, in real time on the fly. But Andy, this I think is a problem. So there's fatigue, which is one thing, because nobody wants to think about this stuff anymore. We're so over it. There is a part of us that just wants to sort of go enjoy the sunshine and forget this stuff exists. And it's easy to when it's not spreading. But there's another part of it, which is skepticism.
Yep.
And that is a high hurdle to get over, especially, I know as a parent, I'm sitting here thinking, okay, what do I need for my kids? What about me? Is there a sequence? Can I get everything at the same time? Should I get everything at the same time? It's very unclear. Am I getting a COVID vaccine every year? I don't even know. I'm not even sure. And I will plug in and do the work to find out and talk to my provider, but that's not everyone perhaps is in that situation. How can we think about the skepticism part and frankly the misinformation part that we know has spread in the vacuum of reliable information?
Part of that is sort of science-based. And, I always emphasize, I live in the virology world, and, the vaccines were still performing the way we expected them, but what we didn't realize was the virus changed so quickly and so extensively during this just a couple of years that it was circulating that it sort of sent the message that maybe the vaccine isn't working. It was really the virus changing and becoming something very, very different from when it first emerged. That's not an easy message to get across to the general public, but it's one of those things that I think now that we're settling into a more routine COVID-19 vaccination. We'll get some more recommendations in the next couple weeks about what's happening in the fall. I think now is a great time to sort of reset everything and understand where we're going with that vaccination strategy, reaffirming the fact that these vaccines are working very well, and now setting the expectations in a way that people would be much more understanding of it. Yeah. Those first vaccine studies, 90+% efficacy, even when I saw that, I thought, wow, that is crazy efficient, but there was certainly that didn't stay as high because the virus then continued to change and get better at infecting people. So now we're settling down into a place where I think the messaging will be a little bit more straightforward and simple. We just have to really sort of double down and make sure that we're communicating effectively that.
Yeah, we were focused on the vaccine when we should have been focused on the nature of the virus. Vivien, is this, that's a really, really good point. And I think because we're not virologists, we all, we see the movies where it morphs all the time and we're concerned, but we've convinced ourselves that's science fiction. Are viruses getting smarter? Do we have to think about this? I know that when you talked about the animal part, I tend to think, all of us think that somewhere in some developing world country at some animal market that doesn't have anything to do with my life, sitting in a, first world, developed world country, what do we need to understand about the nature of viruses? Because that morphed as quickly as we were moving, and we were breaking things, moving so quickly. That should have been, I think, a shot across the bow for a lot of people.
Yeah, these are all RNA viruses that we're talking about here, and these are viruses that change very quickly. I think we're more used to influenza changing, as I think most people are generally aware that we update the vaccine mostly every year for, again, 3 to 4 viruses that are in that one shot, right? So it's not just a vaccine for one virus, it's for multiple viruses. But when we think about the other side of it, the animal-human interface, a lot of these viruses, before they're in people, they do come out of the animal population. And so this is the pandemic threat that we are constantly aware of. And we're exercising each year with seasonal flu in people to also be ready for what may change and move out of either the wild bird or swine populations anywhere, but even in the US. It's going to be swine flu season, right? Where there could be a potential pandemic.
So you're talking about two different things. You're talking about the seasonal flu that we're all used to, but you're also talking about using all the lessons learned for the next pandemic. This is not a seasonal flu that we deal with. This is the potential for another type of global pandemic.
Yeah, it's like two spaces.
That's extremely important, and I think when we broadly talk about influenza, we do not think about it that way.
Right, and right now we've had the largest avian flu outbreak in the history in the U.S. of H5 influenza in the avian space, impacting poultry and wild birds. It's global as well, and so this is a space that we have been pretty much leaning into and responding to kind of behind the scenes. It's really good news that we have not had, we only had one case in the U.S. in 2022, but globally there have been 13 cases. There was one fatality actually in Cambodia, and this was a really good example of where we had people on the ground. We had very strong collaborations in the global space. We worked with over 100 countries over the past 20 years to build that capacity so that we had a rapid team that was able to get data quickly on that virus that actually killed a small child. And then also her father was infected as well. So we were really concerned that this was evidence that this avian flu virus was moving from person to person. Turns out they were separate exposure events from sick poultry. So it was not human-to-human transmission, but we were able to get that information within days, not only in the field in Cambodia in collaboration with the Ministry of Health and, again, CDC staff and other collaborating groups there, but also to have our folks in Atlanta help get that information out. And, we're really concerned about, do we have a vaccine? Do we have antivirals? Do we have diagnostics that can detect and pick up this virus should the situation change?
That should be a real wake-up call for all of us. As we wrap up, I would like to, Andy and Dave, for you to both comment on this, because rightly so, we talked about fatigue, we talked about misinformation and kind of coming out of COVID and trying to communicate better. But this is a great example of potentially the infrastructure improvements, the surveillance improvements that we can build on, now being aware of how rapidly you need to identify the problem in order to jump in and get ahead of it. That may be a silver lining that we can build on. Andy?
Absolutely. I think maintaining capacity has really been my mantra over the last couple of months, because we showed how much we could do in the COVID pandemic to keep track of the virus. Those same tools, those resources can be now turned to provide us with a better, broader surveillance in the human population to understand these infections at a deeper level and to get better care to people then, because there are a lot of vaccines, a lot of antivirals out there. Sometimes that data of really capturing how much of an impact a particular virus has on us as a population isn't there. And when we have that data, that gives us one more piece of evidence that we can go to the population and say, look, 40% of you got infected with a particular strain of RSV last year. We should do something about that, and we can do something about that.
And data, as we know, I'm sure it's going to thread through this conversation, is king and can be a really powerful tool. And globally, our ability to globally coordinate, we saw what could happen when everyone was on the same page with COVID. I'm guessing that the challenge is in the last mile, because you were talking about the point of care and getting that information out then through the community. That's something that sounds like where the benefit from infrastructure from COVID is now in place and we can build on it. That last mile is going to be a challenge.
Yeah, it is. And one thing to just highlight, before COVID, everybody was preparing for an influenza pandemic. So the world was, the world's health authorities, CDC, WHO, all of the health authorities around the world were preparing for that. And I would say that we came out of the COVID pandemic better because we had an influenza program on an annual basis. So the infrastructure that was used during the pandemic, the COVID pandemic, was built for influenza.
So some of the rails were there already.
The rails were there, and it was intended to be, I mean, you heard the comment that each year is a dry run for a pandemic. So the better we can implement a seasonal program, the better prepared we are. Seasonal flu program, the better prepared we are for a pandemic, whether it's influenza or COVID or something else. So I think that last mile of implementation is absolutely critical because speed is everything at the onset of a pandemic.
And I think underscoring the severity of it, because we do come out of that thinking, okay, well, we were worried about dying in COVID. If we just get the flu, we'll push through. We have a different conversation when it comes to our children, I think. We're on it for them, but as adults, we kind of think, if I've got to make a choice and I've got all these vaccines I have to get. Vivien, it sounds like we need to message on that and the worry that was there before COVID came into our lives.
Yeah, I mean, there are antiviral treatments available for influenza. They've been around for quite some time, and early treatment is key, right? So the sooner you get treatment, your symptoms are going to decrease. You're not going to be sick for as long. I'll take those odds. I'll be happy to not be sick for as long with influenza. So yeah, I think getting that message out and making sure that people are aware of the tools and the resources that are available to them from the history that we've had so much for flu is going to be really important.
And one thing on the communication side that we learned from COVID, while, as Andy had mentioned, at the beginning, with the efficacy numbers were fantastic when the vaccines came out, and then the viruses mutated, and the conversation changed to minimizing disease and hospitalization, and it worked very, very effectively. That's something to really transfer to the influenza discussion, because each year we simplify the discussion around the effectiveness of flu vaccine in the context of efficacy. Did it stop? Did it prevent it? Or was there a breakthrough? And those numbers could be somewhat underwhelming. But if you start talking about it, well, even if there was a breakthrough, did it minimize the impact or the hospitalization or the mortality? That's a completely different conversation.
And much easier to measure as well.
Yeah, and it's a much more important outcome, right? It'd be great if we could stop the disease completely, but if you've come out of it and you've minimized the burden and you've prevented hospitalizations and hopefully some death, that's that's the goal, right?
That is the goal, and it sets the expectations. Well, we're out of time, but I feel like we're all more prepared heading into the fall, as we should be, so thank you all for that.
Thank you.